45 years old right-hand dominant railroad worker fell at work onto his right hand. He develops pain in the wrist, a painful snapping sensation, and weakness of the pinch and the grip strength in that hand. He was treated with an extended period of splinting and non-steroidal anti-inflammatory medication without any success. Subsequent radiograph demonstrated a scapholunate dissociation with dorsal intercalated segmental instability. Wrist arthrogram demonstrated a disruption of scapholunate interosseous ligament. The patient was referred for treatment at 9 months delay. On examination, the patient has localized tenderness at the dorsal aspect of scapholunate ligament. Scaphoid stress test results in pain and audible and palpable snapping. Range of motion of the wrist was full and comparable to the contralateral side. Pinch and grip strength was nearly 50% compared to the contralateral side. The physical examination should include both extremities unless otherwise indicated. The contralateral side is an excellent measure of the patient's normal baseline regarding range of motion and level of physical laxity. When attempting to assess whether or not scapholunate dissociation exists, one should pay particular attention to any tenderness at the level of a scapholunate joint, particularly at the dorsal aspect of a scapholunate joint, and on average located proximally about 1 centimeter distal to the listed tubercle. A Watson test or a Watson-Crick test or a scaphoid stress test is also useful to assess whether or not there exists an abnormal mobility at the scaphoid. Occasionally, a painful audible snap can be elicited during this test. The radiograph demonstrates a foreshortened scaphoid with a positive signet ring sign with an increased scapholunate joint space on a AP view. There was a DC alignment on the lateral radiograph. Previous wrist arthrogram demonstrated communication between the midcarpal and the proximal wrist joint through the scapholunate joint. Appropriate radiograph should be obtained including standard PA, lateral, radial deviated, ulnar deviated, oblique and AP supinated clenched fist views of the wrist and the hand. Radiograph of the contralateral wrist can be obtained and are quite useful for comparison. A significant scapholunate dissociation will result in carpal instability dissociative CID type of lesion that typically will result in a DC pattern of carpal malalignment. This carpal instability pattern has been well described regarding its particular radiographic features, which include the following. Number 1. Scapholunate gap. The intercarpal distance between the scaphoid and lunate on the AP radiograph is increased compared with the other intercarpal spacing. The scapholunate gap greater than 3 mm is considered diagnostic of a scapholunate dissociation. The scaphoid gap had been lately called Terry Thomas sign after a famous English film comedian dental diastema. This increase in the scapholunate intercarpal distance is most noticeable both in biomechanical and clinical studies in the AP supinated clenched fist radiographic. Number 2. Shortened scaphoid. The scaphoid assumes a flexed posture as a result of its dissociation from the surrounding carpal bones and assumes a shortened appearance in the PA and the AP radiographic views. Number 3. Cortical ring sign. The flexed posture of the scaphoid results in an end-on view of the scaphoid tubercle and distal scaphoid, which results in a most prominently visualized circular cortex of the scaphoid. Number 4. DC pattern of the carpus. The scaphoid assumes a flexed and a dorsally subluxed posture. The lunate assumes an extended and a volarly subluxed posture, and the capitate lies in a flexed posture. Number 5. Telensic P sign. The intersection of the polar edge of the scaphoid outlined when the scaphoid is flexed, intersects with the volar margin of the radius at the more acute angle than the normal wrist, in which there is a more gentle or a wide C-shaped pattern of intersection. The scapholunate dislocation can be seen alone or in combination with fractures. Carpal alignment should be routinely assessed in any distal radius fractures, including radial styloid fractures. Arthrography can be utilized to assess the presence of ligamentous disruption of the wrist. A wrist arthrogram, although helpful to identify ligamentous disruption, is not able to characterize the size or degree of ligamentous disruption. Also of note is the fact that dissection of the wrist in cadaver demonstrate 28 to 30% incidence of scapholunate interosseous ligament disruptions. In the dissections where both left and right wrists were evaluated, it was noted that if scapholunate interosseous ligament disruption was seen one side, there was 66% incidence of disruption on the contralateral side. Therefore, although reasonable as part of the workup, a positive arthrogram should not or in itself be considered pathognomic of scapholunate instability, particularly in older population. One should attempt to determine in the history if there was any significant degree of trauma resulting in sufficient force to disrupt the normal anatomy of the wrist. Most typically, the pathognomic resulting is a scapholunate dislocation includes an hyperextension force on the wrist with concomitant forearm pronation and intercarpal supination. If a patient has a history and a physical examination and diagnostic workup that consists of scapholunate dislocation, but the radiograph are equivocal or the question of articular damage or degenerative changes remains, the treatment approach is offered to the patient is manual examination under anesthesia and an arthroscopic assessment, including proximal wrist and mid-carpal joint examination. Wrist arthroscopy can assist in confirming whether or not the disruption is acute in nature. Additionally, a concomitant chondral or osteochondral lesions can be identified. There has been reports of treatment of scapholunate dislocation by arthroscopically assisted close reduction and percutaneous spinning of the scapholunate dislocation. If this treatment obtains some success, it can result in anatomical reduction of scapholunate articulation and adequate healing of the dorsal segment of the scapholunate interosseous ligament complex, the dorsal intercarpal ligament to the dorsal aspect of the scaphoid, and DIC to the dorsal aspect of the lunate. Although arthroscopic assisted close reduction and percutaneous spinning of the scapholunate dislocation is preferred as an alternate treatment, the treatment of choice to confirm the diagnosis and the absence of degenerative changes, and once confirmed to proceed with open reduction and repair reattachment of the dorsal component of scapholunate interosseous ligament and the DIC ligament are somewhat in a gold standard. Imagine the forces acting on the scaphoid and lunate to cause scapholunate dislocation, and these are significant forces. So a close reduction and cast immobilization alone is not an effective way to deal with. Moreover, close reduction and percutaneous spinning itself is an adequate treatment. It is not an adequate treatment, although arthroscopic assisted reduction and percutaneous spinning fixation may offer a better assessment to whether or not anatomic reduction is obtained than a plain radiograph. If there is no carpal instability, non-surgical management with immobilization and non-steroidal anti-inflammatory medications is sometimes beneficial. As we previously discussed, mostly the patient proceeds with the surgical intervention. The patient is placed in a supine position with a hand on arm table. Tourniquet is placed on the upper arm. Either regional or general anesthesia is used. Initially, manual examination of the involved wrist is performed, followed by an arthroscopic examination of the proximal wrist joint and the mid-carpal wrist joint, if appropriate. The arthroscopic examination is performed with the hand in the upright position with the assistance of traction. Once the diagnosis of scapholunate dissociation and the absence of degenerative changes is confirmed, the extremity is taken out of the traction and placed in a pronation on the hand table. The surgical approach utilizes a dorsal longitudinal incision made over the dorsum of the wrist, just ulnar to the Lister tubercle. The skin incision is carried out to the extensor retinaculum. The dorsal venous complexes of the wrist should be saved whenever possible, and the dissection plane is extended radially and ulnarly over the extensor retinaculum. A step-cut incision is made in the extensor retinaculum, leaving a radial and ulnar-based flaps. The terminal branches of the posterior trochleus nerve are identified at the floor of the fourth dorsal compartment, lying immediately to the ulnar side of the septum, separating third and fourth compartment. A segment of the terminal branches of posterior trochleus nerves is harvested, making sure to resect the nerve proximal to the distal end of the radius. The extensor tendons are retracted and the transverse incision is made through the wrist capsule, just proximal and parallel to the DIC ligament. DIC is often not easily identified from the dorsal approach. Running a probe or a closed forceps from distal to proximal over the dorsal capsule help isolate the thickened edge of the tissue, which is the DIC ligament. The capsular incision is then extended proximally and obliquely parallel to the radial aspect of dorsal radiocarpal ligament. The DIC ligament can be reflected distally if it is an acute injury. If it is a chronic injury, the DIC ligament has typically contracted and already lies distal to the normal level of attachment of lunate and the dorsal groove of the scaphoid. Most typically, the central, more membranous portion of the scapholunate trochleus ligament and the more substantial dorsal distal portion of the scapholunate trochleus ligament complexes are usually avulsed off the scaphoid. The DIC ligament is often avulsed off the dorsal groove of the scaphoid, and it is also often detached from the dorsal aspect of the lunate. The proximal wrist and the midcarpal joint are examined through the capsular incision for an osteochondral or chondral lesion. Any free ligaments are excised. A trial reduction of scapholunate joint is performed manually, and if there is a difficulty in obtaining the reduction, a 0.062-inch diameter K-wire can be placed dorsally in the scaphoid and in the lunate and used as a joystick to assist in the reduction. While maintaining the scapholunate reduction, a 0.04-inch K-wire are used percutaneously pin the scapholunate joint both from the radial and from the other side to maintain the reduction. Now, once the scapholunate joint has been pinned, radiographs are obtained to confirm the reduction in both AP and the lateral radiograph. Once the reduction is confirmed radiographically, a 2.0 or 2.5 mm suture anchor is placed in the dorsal rim of the proximal half of the scaphoid in the area where the dorsal segment of the scapholunate trochleus ligament and the DIC ligament have been avulsed. Another suture anchor is placed at the dorsal aspect of the lunate. If the DIC ligament has been avulsed off the lunate, the suture attached to the scaphoid sutures anchor is utilized to reattach the dorsal scapholunate interosseous ligament and the DIC to their origin in the scaphoid. The suture attached to the lunate suture is utilized to reattach the DIC to its origin to the lunate. If the injury is chronic and the DIC has contracted and lies distal to the normal location, the DIC is released distally while maintaining its triquetral attachment and is relocated and attached to the lunate of the scaphoid. Once these sutures are tied, the same sutures are used to repair the capsular incisions with a slight west-over pant imbrication. Reattachment of the proximal membranous portion of the scapholunate trochleus ligament has been described. This portion of the ligament, however, is often seen to be disrupted or attenuated in several cadaveric studies. Mechanically, it is not as as substantial as the dorsal portion of scapholunate interosseous ligament or the DIC ligament, as is an intra-articular structure bathed in synovial fluid with questionable potential of healing. In addition, the degree of further dissection of the scaphoid to place the drill holes and sutures for the attachment of membranous portion of scapholunate interosseous ligament is more substantial and is of any questionable benefit. Postoperatively, the wrist and forearm are immobilized in a long arm splint with the forearm in slight pronation for 4 weeks. The wrist is then immobilized in a short arm splint for additional 8 weeks. Radiographs are obtained perioperative postoperatively at 1, 2, and 4 weeks to assess the carpal alignment and pin position. The skin sutures are removed at 2 weeks. The signs of pin tract and inflammation and the drainage should be treated with suppressive antibiotics until pin removal. The pins here are removed at 12 weeks. The wrist is placed in a removable short arm water splint and gentle active range of motion exercise are begun. This is a post-immobilization period of stiffness that either the activity of daily living or the addition of formal therapy will help to resolve in 3 to 6 months' time.